Hello students, welcome to chapter 21, the last part of this chapter. We are going to talk about end-stage renal disease, hemodialysis, peritoneal dialysis, and then nutritional therapy for these patients. So end-stage renal disease is when the chronic kidney disease advances to its end stage. Life support decisions face the patient, the family, and the physician. And to make the diagnosis of ESRD, the end stage renal disease, from now on ESRD, the patient glomerular filtration rate must decrease to less than 15 ml per minute, okay, in body surface area. So this decrease in GFR, the glomerular filtration rate, indicates irreversible damage to a majority of the kidney's nephron. At this point, the patient has three options: long-term kidney dialysis, or kidney transplant, or conservative care such as hospice. Remember that the kidney does not regenerate like the liver, right? So when less nephrons are working means that the kidney function is totally compromised. Dialysis and kidney transplants prolong the life of an estimated 720,000 people in the United States annually. Dialysis is the principal treatment for ESRD, end-stage renal disease. There are two forms of dialysis. You can have hemodialysis, hemo related to blood, right? It's through using a vascular kind of IV procedure, right? And peritoneal dialysis, in which the dialysis is done using the peritoneal cavity, right? And this is more like home treatment. So for hemodialysis, the use of an artificial kidney machine to remove the toxic substances from the blood and to restore nutrients and metabolites to normal blood levels is the most important. Remember that many components in the kidney, the goal is to reabsorb, to filter, to excrete. We are talking about potassium, sodium, chloride, blood, glucose. So many of these are going to become toxic if the kidney is not able to filter, reabsorb, or excrete this, okay? So before beginning hemodialysis, the surgeon must establish a vascular access in the patient. This procedure ideally takes place 4 to 16 weeks before the treatment begins to allow for adequate healing. Now, if the patient is diabetic, this healing is going to be a challenge, right? And in that moment, the nutritionist is having a very tough job, because the healing will take probably a little bit longer, but it has to heal in order for the hemodialysis to take place, right? The vascular access cannot be used if the surrounding tissues are not healed. So the three basic kinds of vascular access for hemodialysis are arteriovenous fistula, right, which is a combination of two vascular pieces, that's the fistula, arteriovenous graft, and a central venous catheter. So patients on a center hemodialysis usually receive 3 treatments per week when they are in a hemodialysis center, each of which lasts 3 to 4 hours. During each treatment, their blood cycles through the dialyzer, which remove excess waste to maintain normal blood levels of life-sustaining substances, a function that the patient's own kidneys can no longer accomplish. So here we have a graphic. Basically, you can see how the vascular access is done here, right? And how the blood is removed from cleanser, going through a blood pump, and they put some heparin pump to prevent blood clotting, right? This blood enters the dialyzer, right, which is the machine that is going to filter And then we have the venous pressure monitor, air trap and air detector, clamp. And then this is basically the process. There is another graphic here to see what's going on inside the dialyzer. So there is the blood inlet, the header, tube, solution outlet, fibers, jacket, solution, and the blood outlet. So here is where all the filtration takes place, right? And then the types of access for hemodialysis in A, you can see, is done through the very close to the wrist. There is another, this is the forearm arteriovenous fistula. And then you have the B, which is the venous catheter for temporary hemodialysis access. This is the venous catheter here entering this area, similar to the catheter they place when the patient is receiving chemotherapy. And then you have the artificial loop graft here, the C, letter C. So studies indicate that individuals receiving hemodialysis up to 6 times per week, meaning 6 days out of 7, with shorter sessions instead of 3 or 4, experience health benefits such as improved general health and mental health with no reported loss in quality of life. For this reason, some clients opt to do home hemodialysis, during which they perform their own dialysis treatment with the care of a partner or care provider. This is typically 5 to 6 treatments per week, ranging from 2 to 4 hours per treatment. So let's move into medical nutrition therapy for hemodialysis. And the person who is undergoing hemodialysis is an important aspect of maintaining biochemical balance. That's the most important. PEW syndrome, PEW means protein energy wasting syndrome, remains a significant concern for patients on hemodialysis. The loss of muscle mass through progressive protein catabolism is associated with mortality. That is the protein energy waste. That is the consequence of this PEW syndrome. So the goal of the medical nutrition therapy during hemodialysis is to maintain optimal nutrition while preventing the accumulation of excess waste products between treatments. So because there is a lot of protein catabolism, there is also a lot of waste products. So the goal of the medical nutrition therapy during hemodialysis is to maintain optimal nutrition while preventing the accumulation. So the hemodialysis is going to remove the excess waste products, right? So what's going to happen? As we understand in this chapter, the kidneys, the nutrition for kidneys takes into consideration several factors, not only the protein, but the energy, sodium, potassium, phosphorus, calcium, vitamins, and minerals, because the kidney participates in all this process. So for protein, energy malnutrition, as indicated by dietary intake and the biomarkers of protein status, that is a major concern. So a protein allowance of 1.2 grams per kilogram or greater is ideal to prevent protein malnutrition. Remember the amount of catabolism that is going on. At least 50% of this daily allowance should consist of protein foods of high biologic value, like eggs, meat, fish, and poultry, right? Now, energy, the medical nutrition therapy recommendations for energy intake are 30 to 35 kilocalories per kilogram per day to achieve and maintain goal body weight for individuals older than 60. For those individuals under 60 of age, recommendations are 35 kilocalories per gram per day. Interestingly, right? Interestingly, the death rate decreases as the body mass index increases above normal ranges. Okay, so again, um, for those individuals older than 60, the energy intake are 30 to 35 kilogram per day. For those that are under 60 years of age, right, younger than 60, the recommendation are 35, not 30, 35. Now, the unfortunate combination is that decreased appetite is common in end-stage renal disease, right? The lack of appetite. When the glomerular filtration rate falls below 60 ml per minute. And then we are going to talk about sodium and potassium. We know that the relationship is inverse, right? So to limit sodium to less than 2.4 grams per day to control body fluid retention and hypertension. We know the role that sodium take in the fluid retention, the edema, and the hypertension. So reducing sodium restriction further may help manage thirst and help patients conform to fluid restriction. To prevent potassium accumulation, which can cause cardiac problems, limit intake to less than 2.4 grams per day with adjustment based on serum potassium levels as indicated. Now for phosphorus and calcium, with careful monitoring to control for comorbid bone conditions, we know phosphorus and calcium, they have a predominant role in bone structure. The dietary intake of phosphorus recommendation is less than 800 to 1,000 milligrams or 1 gram per day. Calcium intake should not exceed 2 grams per day. So phosphorus 800 to 1 gram per day, 800 milligrams to 1 gram per day, and calcium no more than 2 grams per day, including the amount received through food, dietary supplements, and medications such as calcium-based phosphorus. So this is the part in which the situation gets difficult because it's difficult to monitor how much calcium is going to be present in food, dietary supplements versus the calcium that the patient probably is taking through medications, right? Vitamins and minerals, the general recommendation for all water soluble vitamins is to achieve the dietary daily recommendation intake, right? So for example, vitamin C should be 60 to 100 milligrams per day, vitamin B6, vitamin 9, which is your folate, 1 to 5 milligrams, vitamin B12. Those are the four vitamins that are very crucial. Vitamin, again, B6, folate, which is your B9, B12, right? And then we have vitamin E and zinc. Fluid, the recommendations for patient in end stage on hemodialysis are to limit their fluid intake to 1,000 ml, so maximum 1 liter, plus an amount equal to any urine output. So now peritoneal dialysis, we are switching from hemodialysis to peritoneal. This has the convenience of mobility. Approximately 10% of patients with end stage who are on dialysis use this form of dialysis, is 10%. During this process, the patient introduces the dialysate solution directly into the peritoneal cavity. So that is the solution that is going to filter, is going to clean, right? Now you have continuous ambulatory peritoneal dialysis is a form of continuous dialysis within the body, continuous ambulatory. And then you have continuous cycling peritoneal dialysis is a form of dialysis using an automated device, providing several solution exchanges during sleep hours and one continuous exchange during the day. That's why it's called cycling, because one cycle is through the sleep time and the other one is during the day, right? So here we have the picture in which we can see the continuous ambulatory peritoneal dialysis. That's picture A. A soft tube catheter fills the abdomen with a cleansing dialysis solution, the diaset. This is A. You see the catheter in the abdomen, and I'm gonna close this. And then it has tubes like any IV with clamps, okay? And also we have the picture B, abdominal cavity. So you can see basically how this is done. This is the dialysis solution, and the catheter enters the peritoneal cavity, right? And then we have picture C is a waste and fluid, then leave the body during draining of the dialysis solution. So here you have the drain bag, right? Fresh dialysis solution, and here is the drain bag. It's coming back through this middle transfer set. Okay, medical nutrition therapy for peritoneal dialysis. Um, this allows a slightly more liberal diet, so protein and energy. The intake of protein is going to be 1.2 to 1.3 grams per kilogram. Energy intake recommendations are the same as those for hemodialysis, sodium and potassium depending on the fluid balance status. It could be limited to sodium to 2 grams per day and potassium 3 to 4 grams per day. Phosphorus, calcium, and fluid intake recommendations are they remain the same as those for hemodialysis. Vitamins and minerals, the recommendations are the same for those in hemodialysis. Now let's talk about transplant. Remember, with the end-stage renal disease, we have the three pathway. We have the hemodialysis, we have the transplantation of the or hospice care, right? So in terms of transplantation, kidney transplantation, which is another treatment modality, improve quality of life and survival rates, and it is more cost effective than maintenance dialysis, right? So current advances in surgical techniques, immunosuppressive drugs to prevent rejection, and antibiotics to control infection have helped to ensure successful outcomes. Now, patients that are having kidney transplant have significantly lower rates of cardiovascular disease progression and cardiovascular disease mortality than those who remain in dialysis despite the continuous use of immunosuppressive therapy. So a couple of facts, very interesting facts. Survival after kidney transplant is largely dependent on a successful immunosuppressive regimen with several anti-rejection medications. So it's not only to obtain a new organ, but the patient is gonna live with these medications for life, right? And these anti-rejection medications also includes corticosteroids to reduce the risk for acute rejection. We know that corticosteroids is associated with a number of adverse side effects that specifically alter overall nutrition status. For example, gastrointestinal irritation, steroids causes esophagitis, dyspepsia, peptic ulcer disease, increased appetite, and unintentional weight gain. And this is very significant. It's not a regular a couple of pounds. It's a drastic, dramatically unintentional weight gain because of the steroids. Hyperglycemia, okay, protein catabolism and negative nitrogen balance, fluid retention, yes, growth retardation in children, bone disease, long-term corticosteroid is side effects is osteoporosis, cardiovascular disease and mortality, but the most important is that corticosteroids are kind of making your immune system sleep, to be dormant. So some infections are going to be hidden because of the steroids. Now, the difficulty with transplantation is that waiting time can be long and donor matches difficult to find. So those are facts that you need to consider, the patient and the provider and the family. The dietitian works with individuals who have undergone a kidney transplant to ensure highly individualized medical nutritional therapy that takes into consideration any comorbidities and level of kidney function after surgery. So on top of the transplant, if the patient has different comorbidities, that's also another challenge. Complications, bone disorders, right? Malnutrition, anemia, hormonal and blood pressure imbalances, depression, and diminished quality of life because of constant dependence on treatments, right? Um, so this is basically the patients that are in end-stage renal disease and dialysis, right? That's important to understand. Enteral or parental nutrition support. This usually means that the patient is experiencing severe malnutrition. That's why he needs enteral or parental. Not only malnutrition, but inflammation and anorexia. The type and tolerance of dialysis is a consideration when choosing an appropriate nutrition support modality, as well as the current glomerular filtration rate. That's important, right? Metabolic state, stress, and nitrogen balance. Now let's talk about osteodystrophy, right? Osteobone dystrophy, atrophy of the bones. Bone disease and disorders are prevalent in cases of chronic kidney disease, and they are a leading cause of morbidity. Several factors contribute to renal osteodystrophy. The decreased activation of vitamin D has a cascading effect that results in elevated levels of parathyroid hormone, reduced calcium absorption from the gastrointestinal tract. And this is something that you need to start motivating yourself to understand how this process, this circle, okay, is a circle of events between vitamin D, parathyroid hormone, little by little, because when you get to the fourth semester and we will explain the musculoskeletal system, you need to understand this, okay? You have to be able to understand and process all the information. So, as I said, the decreased activation of vitamin D has a cascading effect that results in elevated levels of parathyroid hormone, reduced calcium absorption from the gastrointestinal tract, and low serum calcium levels. Patients also have elevated serum phosphorus because of the inability of the kidneys to excrete phosphorus. So it's like a domino effect. This combination causes abnormal changes in bone structure and function. Hyperphosphatemia is associated with increased mortality risk. Thus, phosphate binders are an important management aspect in chronic kidney disease. The healthcare team will evaluate patients with GFR, glomerular filtration rate, less than 45, for bone disease and disorders of calcium and phosphorus metabolism. So here is a very, very, very interesting table. It's a recommended nutrition guidelines for adults with chronic kidney disease. On the left side, we have the chronic kidney disease stages 3 to 5 with the GFR, glomerular filtration rate category 3 to 5. In the middle, you have chronic kidney disease stage 5, which is kidney failure. And then on the right, you have post-transplantation, guided by chronic kidney disease stage category of kidney function. Okay, so in terms of nutrients, right? So on the left, you have stage 3 to 5, in the middle, stage 5, and then in the right, post-transplantation. In terms of protein, the requirement is higher when the chronic kidney disease is in stage 5, so you need more protein intake. In terms of energy, it looks similar, 25 to 35 in the three cases, right? 3 stages. Let's talk about fat. In terms of fat during stage 5, you have to focus on type of fat and carbohydrate to manage this lipidemia. But post-transplantation, you have to monitor the fat to reduce cardiovascular risk or manage immunosuppressant medications. Now, talking about saturated fat, in terms of in stage 3 to 5, you have the same as for general population, minus 7% of total fat in the diet. In terms of sodium, pretty much is the same. In terms of potassium, in stage 3 to 5, typically no restricted until hyperkalemia is present. Then in stage 5 is 2 to 4, right, the potassium, 2 to 4 grams per day, or 40 milligrams per kilogram. And then after transplantation, no restriction unless hyperkalemia is present. And that's important because you don't want to have any cardiac issues. Then calcium, 2 grams elemental day from dietary and medication sources. This is in stage 5. Then for phosphorus in stage 3 to 5, typically there is no restriction until hyperphosphatemia is present. Then in stage 5 is 800 to 1000 milligrams or 1 milligram, right? And post-transplantation is individualized to a stage of kidney function. That's important, right? So how well is the kidneys? And then they are going to decide how much phosphorus the patient needs. Fiber is in the 3 cases the same. Fluid is 1000 ml per day in stage 5. So neuropathy, in the absence of functioning kidney, in the absence of functioning kidneys, toxic substances accumulate in the blood, resulting in a uremic state. These toxic substances damage nerve tissue and lead to painful neuropathies in the majority of individuals with end-stage renal disease. Central and peripheral neurologic disturbances may be present in the initiation of dialysis, particularly for patients with diabetes, and symptoms of neuropathy are more common when glomerular filtration rates falls below 20 mL and when serum creatinine levels rise. And we need to remember that creatinine is the most reliable factor in order to see kidney function. Okay, so you see this topic is not easy. Kidneys play a role in too many organs. The nervous system, the kidneys are going to regulate blood pressure, they are going to activate vitamin D, they are going to filter electrolytes, they are going to check for blood pressure, for acid-base balance, they are going to regulate the malnutrition through monitoring of the protein catabolism. So it's a lot to monitor, and we have to control all these factors based on the kidney disease stage from stage 1 to 5, and then the end stage renal disease, which has his own parameters for nutrition and survival, right? So with this, we have concluded this chapter. Very interesting. Don't get anxiety thinking that you need to memorize all these numbers in proteins, in, energy. No. This is for the dietitian, but at least you need to make the difference between how the requirements on the nutritional requirements change based on the stage of the kidney disease. Thank you so much. This is the end of the chapter. Bye.